Dr. Scholes, in PCRI, we talk about all types of prostate cancer, and we talk about all types of treatments, but one treatment that is talked about in all cancers is chemotherapy. Now, chemotherapy in prostate, I think of it a little bit different. I think about it in that it seems to be more tolerable than a lot of other cancers comparably, maybe because of the way it's created and also how it's given in prostate cancer. So I thought that maybe we can talk about how chemo is given, what is traditional, what isn't traditional that could be effective, and then really where do we see chemo fitting in, considering there are so many types of treatments out now. And I think that now that we have these new hormone therapies, we have lutetium, we have Xofigo, we have all this happening, we want to know really where should chemo start, and should we wait, should we not wait? So first of all, can you define chemotherapy in prostate cancer compared to other types of cancer?
For many cancers, chemotherapy is the only venue for effective treatment if the cancer is spread. And you'll often have several layers or cycles of different types of chemotherapy. If one doesn't work, you'll move to another one. We have a little bit of that in prostate cancer, but when we talk about chemotherapy in prostate cancer, we're really talking about either Taxotere or Jevtana, which are kind of close cousins. They're very similar medicines. Single medicine given in modest doses can be very effective in prostate cancer, and it is a useful product that can help people really at two different stages. We think of the men who present, maybe didn't get PSA testing, and they come in and they already have metastatic disease. That's one role for chemotherapy in the modern prostate cancer world. People tend to think of chemotherapy as sort of, in prostate cancer, as sort of a last-ditch effort. Everything else isn't working anymore. Now we'll try some chemotherapy. And so those are the sort of the two settings that we're seeing the usage of chemotherapy now. It's sort of sad to use that word because in other cancers, chemotherapy could mean that you're getting 2 or 3 medicines concomitantly. Of course, the side effects go up when you use more medications. So the tolerability of Taxotere in the prostate cancer patient generally is quite good. And it is somewhat inconvenient because it has to be given intravenously. It's not a pill. And of course, people can get hair loss and they can have some fatigue as a result. So it's not a small undertaking to take Taxotere or Jevtana, but in general, it's an effective medicine and oftentimes quite well tolerated.
Before I get to my next question, I just wanted to remind you that we're a nonprofit, and if you would like to join our cause to get these videos out to people all around the world, you can do so at pcri.org/donate. Now back to our conversation on chemotherapy. So when you have patients who are diagnosed with maybe advanced prostate cancer and maybe they didn't get, their doctors or physicians didn't suggest PSA testing, is chemo the first conversation you would have with them, or what criteria would that be?
Those people, so let's say they come in and their PSA is 100 and they have a scan that shows some spread to the bones, are typically managed with a combination of hormone treatment and chemotherapy. And this is a fairly well-worn pathway now. So they'll get 6 injections of Taxotere over about a 15-week period. They'll be placed on a first and second generation hormonal agent, which will continue for 18 to 24 months. If there's a limited number of metastatic lesions, those lesions will be radiated. So we call that oligometastatic disease. And they'll radiate the prostate as well. So that's a fairly straightforward program. In the men that have advanced disease, that maybe they've been on hormone therapy for 10 years, it stops working, they are developing progressive problems with spread to the bones. When chemotherapy is used in that setting, it is not such a fixed proposition. You can give the chemotherapy on a weekly basis, you can give it every 3 weeks, you can go for 15 weeks as we talked about previously, or you can go for a shorter or longer period depending on whether or not the PSA is declining.
When we talk about chemotherapy being an injection, what is that process like for the patient to come in and get chemotherapy?
So the medicine is mixed, put in an IV bag, and dripped into intravenously over about a 60-minute period. The patients are prepared in advance with some cortisone pills the day before, the day of, and the day after to soften the blow of the treatment. And men that don't take some cortisone, they can develop some swelling in their ankles. That's usually controlled when they take cortisone. There's anti-nausea medicines that are given routinely. And in our practice, we routinely give an injection of a medicine called Neulasta to stimulate the white blood cell growth so that the risk of infection is dramatically reduced. Historically, chemotherapy without medicines like Neulasta would result in serious infections, maybe in about 5% of the times that you're administering the treatment. And these serious infections, because the immune system temporarily is lowered so much that bacterial infections in the blood can spring up suddenly in 5 to 8 days after the infusion of chemo. And so these medicines, such as Neulasta, Udenyca, there's others out there, which cause a sudden uptick in the white blood cells, essentially prevent these infections and almost eliminate the chances of any serious infection from the chemotherapy. The reason I mention this at length is some offices I've noticed don't have a policy of using those medicines routinely. And it's probably because they're somewhat expensive, and patients will often get through chemotherapy without infections. The policy in those offices is really to wait and see if patients get an infection and then start using the medicine on subsequent cycles. It sounds like a dangerous proposition to me. So patients that are thinking about chemotherapy, I like to advise them to specifically request medicines like Udenyca or Neulasta or Neupogen. There's a number of different products that will give this protective canopy over the immune system while they're going through the chemotherapy treatments.
What type of side effects does a patient experience while they're getting chemo?
So the most troublesome one is that people will feel sort of achy and fluey for 2 to 7 days after each injection of the chemotherapy. When you talk to people who are going through the treatment, they will actually feel sort of on a high when they're on the cortisone medicine, which is started the day before, given the day of, and also the day after. And then after that cortisone medicine wears off, the bottom sort of drops out, and people feel kind of icky and achy and tired for 3 to 5 days after that. Sometimes, if people are struggling a lot, we will discuss with patients maybe continuing the cortisone medicine for a few extra days to kind of help them ride through the process. Historically, people are given low doses of cortisone throughout the whole course, and we don't use that policy in our practice because the rationale for giving prednisone along with Taxotere is founded in some trials that were done 20 years ago where prednisone was the treatment arm when they got FDA approval of Taxotere. In other words, to show that Taxotere could make people live longer, they gave half the men Taxotere, and the other half the men they gave the standard of care, which back in 2002 was cortisone, sadly. That was the best we had. And they showed that Taxotere patients lived longer. But to make the study fair, they gave cortisone in one group of men, they gave Taxotere plus cortisone in the other group because they wanted to have only one variable, the Taxotere. So both groups got cortisone. And for the last 20 years, people have been giving cortisone straight through with Taxotere as if it's part of the treatment protocol. There's really no rationale to give it continuously, though sometimes we'll give it a short burst of it after each cycle so that people will feel better.
So when we look at the media's depiction, you see it in movies, you see it in stories where people are getting chemo. You see people losing their hair. You see people sitting in the chairs, and it looks like quite an arduous process. Is that the experience of a patient who has prostate cancer and is going to be taking Jevtana or Taxotere?
Hair loss, to a very significant degree, occurs in at least half of the patients. It's not a permanent thing. As soon as the Taxotere is stopped, the hair starts coming back. There are ice caps that are used, they're covered by insurance actually for breast cancer patients. They're not covered, unfortunately, and they are somewhat expensive for men that want to preserve their hair who are taking Taxotere. It's a very specific methodology, so just putting some ice on your head is not going to be enough because what you'll have is patchy hair loss. Whereas with these sophisticated devices that really ensure that there's uniform cooling of the whole scalp, they're very good at preserving hair, so there won't be any hair loss. But since it's not covered by insurance, it's kind of pricey.
Are there any issues? I know with some treatments there are issues to the salivary glands or fingertips, and some numbness. Is there any issue with chemo?
Yeah, so we call that peripheral neuropathy, which is a common side effect. It's not too noticeable, usually until people get into their 4th, 5th, and 6th cycle of the medicine, although it could occur sooner. It slowly reverses when the chemotherapy is stopped, but we don't have any specific way to prevent that from happening. It's just a known side effect of the medicine and can create this numbness and tingling in both the toes and the fingers in some cases, not everybody. The other thing, of course, is if patients, particularly when they were giving the low-dose weekly type of Taxotere, sometimes in elderly men, we're a little concerned about giving a big bolus of chemotherapy every 3 weeks, and to mitigate the tiredness and the impact on the white blood cell count, we would give a smaller amount on a weekly basis. And the treatment is quite a bit more tolerable in that manner. However, repeated constant exposure to the fingernails can cause more problems with fingernail growth. And so in those patients, we ask them to keep some blue ice and put the tips of their fingers on ice during the infusion to shunt blood away from the fingertips. We also have people put ice in their mouth during the infusions because the taste buds are very sensitive to these chemotherapies. And by keeping blood flow low to that area of your body during the infusion, there's less exposure to the chemotherapy.
So after somebody, let's say they got treatment on Monday and 7 days later, what type of side effects should they expect or experience? How long does the fatigue last? Is there any issues that they need to be aware of?
I would say on average, the fatigue lasts for 3 to 5 days, but there seems to be a cumulative effect where each cycle seems to take people down one more notch. Now, it's not universally true. Some people skate through these medicines, Taxotere and Jevtana, they do very well. But others, and more commonly, they'll say that each cycle seems to just get a little bit tougher in terms of the recovery period, the duration of tiredness. For this reason, we've often just unilaterally decided to give 4 treatments rather than 6 treatments. In patients that are doing adjuvant Taxotere, which is becoming a more common thing, where we're trying to take someone who's in a complete remission and improve their chances of cure to perhaps 10% or something like that. My belief is that the lion's share of the benefit from these medicines occurs in the first 4 cycles, and the lion's share of the toxicity occurs in the last 2 cycles. So by dropping off cycles 5 and 6, I think we're squeezing a lot more value out of this treatment without incurring quite as much damage.
I've heard that Tanya Dorff with City of Hope, she's a medical oncologist who specializes in prostate cancer and many other cancers, but she definitely is an expert in prostate. She has talked about fasting being a good thing for patients who are going on chemo. Now, is that for effectiveness? Is that for how a patient feels? For what purpose would you fast? And for how long?
Right. So this is an interesting area of research. It hasn't been proven to be effective. I've had some patients implement short fast of about 18 hours before getting their Taxotere and reporting that they seem to see less side effects as a result. The rationale behind fasting prior to the chemotherapy is that that when we don't eat, our normal cells tend to go into more of a resting state, and they're less likely to absorb the chemo or take it in from the bloodstream, whereas cancer cells just want to grow and they're pedal to the metal all the time. They're not going to slow down, so they will not selectively slow down when we fast. But since our normal cells do, they will not absorb as much of the chemotherapy, and therefore we would have less side effects. I don't think it's a proven fact. I don't think the studies are clearly in that will prove or disprove that particular premise, but I have seen patients implement this and have reported that they seem to have somewhat less fatigue when they fast prior to their infusions.
One comment that I got from a patient who was doing chemotherapy was that he was trying to do weightlifting in between the time that he was doing chemo. And I thought, first of all, very commendable that he's trying to do weightlifting when he's taking chemotherapy. Do you think that this would be helpful for the sake of tolerating chemo?
Over and over, no matter what the treatment, whether it's radiation or hormone treatment, and including chemotherapy, when studies are done comparing people who pursue a fitness program during the time that they're going through this, and this is a physical challenge to people when they do these things, whether it be chemo, radiation, or hormone treatment, the results are really clear that the patients that are able to do some fitness training, they may have to ramp it down because of the sense of tiredness that they're experiencing, but if they're able to persevere and do some fitness training, they report far fewer side effects. It's a difficult prescription to lay on someone when they're feeling kind of blah from the chemotherapy. But if they have a way that they can even just go through the motions and do minimal fitness training, they tend to do much, much better.
So today I talked to Dr. Scholes about chemotherapy. As you've seen, the main point of this video is we want to bring up information that maybe not every patient knows. If you are taking chemo and they haven't mentioned Neulasta or something like it, bring that up with your physician. Use ice chips if you need to. Here are some of the ins and outs of what Dr. Scholes does as a medical oncologist, where he has seen patients go through chemo treatments time and time again. One of the points that I think is very important is we want you to make sure that you have the right physician. We want to make sure that you have the right, treatment center, you've gotten multiple opinions. A lot of people think, well, chemo's very routine, so we're going to go with what the doctor says. And obviously he's given tons of chemo before. But, it's even important in those situations to make sure that you have the right doctor and that you're getting the, top of the line medical care that you can. And to see ahead of time, okay, is he talking about Neulasta? Is he talking about different issues I may have? I've even talked to some patients where they weren't given nausea medication during the chemo, and those things can just make that whole process more tolerable. Having cancer and the whole diagnosis, there's so many intricate, arduous situations when it comes to it, having to go to more doctor's appointments. It's such a strain, and we want to make sure that we're bringing up points that hopefully can help alleviate some of that strain and help answer your questions. If you have things and questions like topics that we have not covered before, or maybe you want more clarity, please leave that in our comment section below our videos. And please subscribe to our YouTube channel. We found out that 75% of you don't subscribe. We have hundreds of thousands of people watching our channel, and we would like to get our subscription rate up for one reason. If you subscribe, Google and YouTube see this as even more prominent information, and they will help disseminate it to other people through their algorithms. So that subscription matters to us. And we want to get this, out to as many people as possible. There are millions of men with prostate cancer around the world, and they need our help. So if you found this information helpful, please subscribe, like the video, and again, leave your comments and questions below in the comment section, because this helps us create further videos down the line. Now, if you need help with your particular case, maybe you have some specific questions, you can contact our helpline at pcri.org/helpline, and we'll give you the link in the description below. You can talk to our team, and so they are prostate cancer patients, and many of them have been through the particular situations that you may be asking about, and they're able to kind of give some practical information and email you some information so that you can have better outcomes with your medical team and maybe go into those, doctor's visits with a little more clarity. If you would like to donate, we are a nonprofit. Our goal is to get these videos out to people all over the world. So, if you can't donate, please subscribe. But if you can, that'd be great too. And we just really hope you have a great week. It's an honor that we get to serve you in this way. We really appreciate that you trust us. And please remember, most of all, you're not alone.